Welcome back. Hope you're all teed out. And this is the home stretch now, so we have a nice opportunity to focus on a related issue, but also to try and bring some of the strands that we've chewed over, if that's not mixing too many metaphors, throughout the day, in particular this afternoon. So what we wanted to do in this last session is really think through not just the pace of change of technology and what it might do, but really particularly what it's going to do to the world of professional work, and in particular, if you don't mind and don't roll your eyes, to the world of medicine and physicians. I was in a meeting the other day with someone who said they'd gone to a big US meeting in their specialty, and about the future and future technologies in their particular specialty. And someone midway through this massive congress stood up and said, "The doctor is dead," and then sat down again, and put the fear of God into everybody. So I think we're going to sort of discuss the doctor is dead issue in this particular issue. And I've got a really nice panel here, as you can see. The panel is not quite as advertised because we've had some sickness to deal with on our plenaries. So I'm very, very grateful to the panelists that are here today. We have, next to me, we have Dr. Samantha Roberts, who has two jobs, actually. She is newly appointed Chief Executive of the Accelerated Access Collaborative, which I hope she'll be explaining to us, which is an NHS improvement show, if I can allied the two, but she's also Director of Innovation and Life Sciences, also at NHS Improvement. Next to her, with great thanks, we have Dr. Shanti Vijay, I'm going to say my apologies, Vijaya Raghavan, thank you very much, who is consultant physician. Thank you.
I've been practicing.
Oh, right, okay. Consultant physician in diabetes at Barts Health. Shanti has been very, very busy working for the last 10 years in developing virtual consultations, particularly for outpatients, and I think her experience there would be very, very interesting. Notice the 10-year experience. And then next to her is, known to many of you, is an old friend, Dr. Fiona Godley, who's the editor-in-chief in the BMJ, who really has a wonderful bird's eye view, doesn't she, of but certainly the medical profession, but things medical more generally. And I think her perspective on this coming revolution would be particularly interesting. So just before that, I was just going to show one or two slides just to get the joint jumping, as it were. I just noticed some recent ONS figures and graphs, and I just wanted to show you with respect to automation and work. So the first one this was some recently published, the probability of automation in England, 2001 and 2017, and what this shows you is just for broad groups of workers where they think what they think the probability of automation is now, the kind of likelihood of more automation hitting, and how profound that is. And so I think what the broad, leaving aside the definitions, what do you mean by automation and what do you mean by probability, I think this is giving you an idea of where they think the automation is going to hit the workforce. And what's interesting here is that, the sort of what traditionally have been called lower skilled or less skilled occupation, elementary occupations, are more at risk, according to this, than the professional occupations, or indeed the managers, directors and senior officials, which are more prevalent in our world, perhaps. So one way of looking at this is what automation, as seen in the future, is likely to hit. But another way of looking at this I was mooting was actually how skilled certain professional or certain groups are in resisting. And it could be, of course, that the professions are most skilled at resisting, which is what we might be discussing a bit today. So that was one slide from ONS. The second is the risk of automation of jobs changes according to where you work. Obviously, case mix here will be involved, what types of work are concentrated in different parts of the country. But as you see, this is not an equal picture, in that London and the southeast, of course, will largely be able to resist these technologies, but those in the northeast and other parts of the country will be more vulnerable to them. And then, of course, that vulnerability translates also into age group. Again, probably there's a case mix here, because the younger you are, the less likely you are to be in highly skilled professionals, because you haven't yet trained up. So there's a vulnerability issue here with the young. So what we're talking about are lower skilled parts of probably parts of the country that have less economic activity, and the young seem to be the most at risk, according to ONS, of automation. And then the last slide I just wanted to show, I have droned on about this book rather a lot, so apologies if you've heard me say this. There was a very, very interesting book of the year by the FT Book of the Year that came out in 2015 called The Future of the Professions, and it's by the Susskind pair, Richard and Daniel, and they wrote this fabulous book about how the future of professions was going to look like with technologies that are coming down the track, and they looked at various professions, one of which was the medical profession. I just want to explain this little diagram for you. So what they were basically saying is that what used to be, they're talking about medicine here, what used to be in medicine was largely a craft. Over time, some of the craft will be standardized, guidelines and all that, and then it will be systematized. For those parts of medical care that really can be protocolized, it will be highly systematized, leaving less in the craft box. So what they were arguing in a nutshell was physicians will be pushed into a craft box, and that anything that they do that could be more standardized or systematized will be given to other people who will be able to do this job just as well, if not better, because they will have assistive technologies at their disposal. And so therefore there is an opportunity here for other workers to take on medical tasks, leaving fewer physicians, but what they are doing is less protocolizable type of work. And then they also said that in addition to that trend going on, there will be another trend, which is that a lot of medical knowledge that was formerly chargeable, if you like, will be available online. At first, it will be chargeable online for highly sort of skilled medical kind of things. Then it will be available, but not charged online, but in maybe commercial sort of boundaries of some sort, companies. And then ultimately, it will become in the commons, is how they argued it. I'm paraphrasing, and you will really need the chapters. So I thought those were two very interesting broad trends to think about in this last session. The changing role of medicine to possibly ceding various areas and moving into a craft area, which may mean highly specialized. It also may mean where you have lots of conditions that you need to manage that simply can't easily be protocolized. And then secondly, the whole nature of medical knowledge will become uncommoditized and externalized and free. And that's where the Google Health and all the others will come into the business and provide stuff free, ultimately charging, but then ultimately it may become more freely available. So if you take that for a minute, take that thesis. I know we've talked earlier on about technology being very difficult to diffuse. I mean, it's highly complex what is now needed to get change fast in technology. But if you'd say that it is going to happen at some point, and this is likely to be the result, it's quite frightening for some clinical people already in this area, particularly the medics at this end, at the craft end. So how are they going to be helped to embrace this agenda and not resist it? And I'll end by saying one of the suggestions, which is kind of bleeding obvious, I suppose, by the Suskins, was that the way into this for done to professions is not to present that their jobs will be disrupted and that they have to kind of respond, but for they themselves, with others, to decompose their tasks and work out which ones are more easily systematized and standardized, where they own the agenda, they embrace the agenda with others, and they don't resist to the point that they are then disrupted, if you see what I mean. They are part of the narrative, they're not the resistors to that narrative. So I think this is the kind of thing we wanted to just sort of draw some threads together. And with that, we've got our wonderful panel, who I'm just going to move over to now, and we'll begin the discussion. So first off, I wanted to maybe turn to Sam, partly because of her exciting new role. She really does have a bird's nest view, eerie view of the system, so to speak, and is really in a position to be able to help accelerate some, which is the theme of the day, some of these technologies that are going to hit the system. So I just wondered whether this sort of analogy is chiming with how you're seeing your work at NHS England and Improvement, and also what are you thinking of to help the professions embrace this agenda and not be fearful of it?
Yeah. So is my mic? Can people hear me? No, I'll just speak louder. I don't think my mic's working. So put your hands up at the back if you can't hear me. Felix, will you put your hand?
I think it's on now.
Yeah. Sometimes when I hear about technology and professions, I feel as though we're setting up a war that will end up being a partnership. And the reason that makes me think that is when we look at a couple of things. So first of all, the AI State of the Nation report. The vast majority of new technologies are or only 1 in 4 have had a CE mark. So that means they're at the very, 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 very earliest start of the innovation cycle. So that's the one fact. The second fact, I think, is some of the work that the Health Foundation has done to look at the nature of the innovation cycle when it's not a medicine, and that actually it's a process of continual adaptation and negotiation between the recipient of the innovation and the innovator. So I think these two facts, the fact that we have lots of very early stage innovations and the fact that we've got a relatively fluid innovation cycle that isn't just phase 1, phase 2, phase 3, TA, funding mandate, do you know what I mean, of clinical trials, means that from now, clinicians and managers and those that are using these technologies are being asked to define the use case, define where it works in their daily life, develop the innovation as they like to see it. And I think that's what your data has shown, is that in almost all the cases where innovation is tested, the innovator changes something about the innovation and the adopter changes something about their practice. So it's actually much more of a partnership than a recipient's kind of, and then the innovator demanding this is the way it's used. So I think that's the world that we're in now. Our responsibility, therefore, to the professions is to make sure that they have the time and space and skills to play that role of the adapter and the person who can find the place in the pathway that it makes sense for this innovation, or within their work role that where it makes sense that this innovation would actually make their life easier or the patient's experience easier. And so I think that's some of the things we're wanting to do through Accelerated Access Collaborative. When we talk about real-world testing, is kind of how do we create these environments where all the members of the health team can come together with innovators and have this kind of negotiation of, you have this innovation, but I actually want to find a place where it's useful.
Thank you.
Yeah.
I mean, we heard of in an earlier session sort of the places where technology are really hitting particular clinical areas.
Yeah.
And one was, of course, imaging and pathology.
Yeah.
Another was in predictive technology and analytics to do with mental health, and another was fetal radiology, again, imaging.
Yeah.
Do we have any lessons from that, where there are some clinician specialties that are kind of just the vanguard of this type of thing, and is there anything that we can learn for other clinical specialists?
So I don't know. So I'm not aware of, but audience, feel free to pitch in here if you know of huge professional groups that are really the vanguard. But more, I'd say there are great examples of where clinicians have worked with innovations to get to this negotiated position. So I think the Moorfields example is a great one, or the work that they're doing on screening mammography is another great one. Where, so I think, from my view, but I'm happy to be disagreed with by the audience, is that it's not whole professions that seem to be adopting these things more quickly, but it's places where clinicians have got the time to develop a use case together with an innovator, implement it in a local setting where it makes sense, and then try to spread it where we're seeing the peaks emerging.
So are you just saying that the clinicians are partly responsible for the velocity in which this thing is taken up, as opposed to being overtaken by events? Because there are some disruptive technologies that are overtaking, and we heard one earlier, which is, of course, the the GP example, the digital GP, where that is quite threatening because it's so speedy.
Yeah.
So are you saying that the types of innovations that you are seeing are likely to be in the slower, more evolutionary box than the dramatic disruptor? Is that what you're saying? And so an addendum to that is that, when you read in The Economist, they had this thing, what is it, the future doctor is you, is what they said in The Economist. And there, the possibilities of all these big tech companies providing all this kind of externalized support is huge, which will take over quite a lot of decision making, at least in some, or at least diagnostic maybe, I don't know. So are you hopeful that the speed will not disrupt and cause resistance, or do you think that there's is the theoretical question, do you think that the speed at which these technologies we're taking up are actually slow enough to be digested by and adapted by the medical profession?
Well, so I think that the digital primary care is the one great kind of disruptor that we see. But if you look across all the other promising areas that we certainly look at, which is screening, diagnostics, risk prediction, early diagnosis, most of those things require something from the existing clinical workforce that is relatively distributed to incorporate it into their daily routine.
To make it work.
So it kind of this is why you get into this negotiated position of, well, if we were to provide, we've had AI for quite a number of years that can count HER2 receptors, but we don't know where that fits into the clinical routine.
Yeah.
So you can have the innovation, but it's not disrupting the status quo necessarily because it doesn't have a place to sit, if you know what I mean.
Yes, it's very interesting because the innovation narrative is a disruption narrative.
Yeah.
And there's kind of public sector narrative, isn't it? That you're so inert, we'll do it from outside anyway.
Yeah, but you can't, it doesn't work.
No. Yeah. But that's still around, and it's also still around in some, let's say, political speeches. That's sort of zeitgeist, isn't it? And that itself will breed resistance, won't it?
Yes.
So you're talking about a very different narrative, which is very helpful. Perhaps we can come back to that. And also, it speaks more to the collaboration narrative, not the competition narrative, which is what we've had for the last 30 years. I think that's the other, isn't it?
Yeah.
Thank you. Can I move on to Shanti? So Shanti, this must sound a bit rich because I'm talking about innovations overtaking the NHS and disrupting the professional sort of sense of identity. But then you've been working on a very relatively simple technology for over 10 years, which is, of course, virtual Skype or whatever consultation. So could you say a little bit more about your experience there? And am I worrying too much about being overtaken by this tsunami of hard-nosed tech?
So, does this work?
Yes.
Yeah. So I'm a physician and I'm a diabetologist, and I work in East London where there is a lot of diabetes because of the local population. And I've been working there since 1996. And if you ask most clinicians about people we see in outpatients, there will always be a group of people there who we don't have to physically bring up for a physical appointment. And, most of us do telephone clinics and emails and texts, and our nurses are brilliant. They see patients all the time out of hours and all sorts of things. But I think we're always struck by how many people we bring for a physical examination. And when that happens to you as a patient or a carer, it really drives home the point that, you don't need all these people turning up for all their appointments if you don't need to do a physical examination or talk about something that can't be done online. So in 2011, we were very grateful to the Health Foundation for giving us some funding as part of their Shine Award there, and Helen and Penny and people like that were responsible for us getting into this in the first place. And it was really just to look at whether it was possible to replace some face-to-face contact with online contact using consumer Skype. So it was making no changes to the pathway, just doing it in one clinic, mine, and one nurse clinic, and just doing some PDSA cycles and looking at what would the acceptance be, what kind of age groups, what kind of things could you discuss. And then at the end of the first year, we felt that the acceptance was quite high till about 65 years of age. There was no gender bias, people loved it. And we thought it could be used as a tool, but then we needed some more money to look at what we came to realize is answering a little bit of the questions you asked before, I firmly believe technology is just a tool to probably deliver more effective care. What you really need is service redesign, because the outpatient process is antiquated, it's not fit for purpose, and there are bits there that need to change, and can you use technology in whatever form it is to deliver this? So we went back to the Health Foundation and got a program grant. And what we did with that over 2 years was look at whether we could co-design a process with patients about it being a more reactive process. So rather than me calling a patient in 6 months, because that's when I have a slot in my outpatient clinic, when there is really no urgent clinical need for the patient, and could we have a more open access system? Whereas a diabetologist, I need to see people once a year to examine their feet, look into their eyes, and have discuss their management plan. I bring them for that, and in between, we have something slightly more open access, where we just use Skype. Patients can ask me when they want to book an appointment or book an online chat, and we just do it in a more proactive fashion. And that was, again, just within diabetes. And then all through this process, we were having this evaluated by our academic partners, who's Trish Grenhalge and her team at Oxford. And then we realized that if we were going to roll this out wider within the organization, within Barts Health, we would need to address various complex issues at various levels. And so we got some funding from the NIHR for a project called Vocal. And what Vocal did was looked at online consultations in various specialties within our organization. At things like, what does it do to the dynamics of a clinician-patient interaction? We looked at, it was an action research project, so we looked at what's the organizational impact of doing online care, so the sticky bits like governance and business cases and tariff and inpatient leaflets and patient advice, and then where does it fit with national policy? And what I found, and I'll tell you a little bit when we talk about obstacles, but really the best bit of it for me is that when you have an online consultation, it fundamentally changes the relationship between a doctor and a patient, and it becomes a conversation of equals. So people say this repeatedly in focus groups and questionnaires and interviews, that when they come to clinic and they sit in your space and you run the consultation, you're in charge of the consultation, you ask the questions, it's one-sided, it does nothing for patient empowerment, it does nothing for self-management. When you Skype a patient at home, the conversation becomes a conversation of equals, and then you start having a very mature conversation about things that they want to talk about. And then we came back to the Health Foundation for further funding, and we were awarded the Scaling Up grant last year. And what we've been doing as part of Scaling Up is looking at 3 pieces of work. One is about what is it that we need to embed this nationally. So, is it hand-holding, help, is it support? And we've set up something called a virtual consultation hub, which is really, if a governance lead wants to talk to our governance lead, we put them in touch. But we also realized one size doesn't fit all. So really working with different teams around the country to look at what are the challenges they face and how is it that could a virtual consultation fit in with what they're planning to do, and looking at different patient populations. And then kind of doing some work nationally around carbon footprint and training of junior staff and so on. So that's where we are at the moment.
Thank you. And how far has the medical profession, your colleagues, embraced this kind of change? Because if you think about it, think what's in the long-term plan, 30% of outpatient appointments to become virtual, isn't it, in 5 years? That's quite fast. How did you find your colleagues?
So the 2 bits to this. One is, as a clinician, I would say that one of the obstacles is the clinical mindset to a large extent among a lot of people. So it's...
Can you unpack that?
So it's same
We think we know what you mean.
Same old. So it's like, we often think that the gold standard is getting a patient to clinic. And, we're risk averse, we're concerned about missing findings, we're paying... patients love coming and seeing us. I love chatting. So I'm quite happy to sit for an hour and talk to people. But actually, when you ask patients, it's not just the ease of access or convenience. They tell you some really interesting stuff. They tell you that when they talk to you online, they have your undivided attention. And that's probably because the webcam is in front, your screen is in front, and you're talking. When I'm in clinic, people walk in and out of the door. I'm looking at the screen, I've got junior staff, I've got somebody else coming and telling me I'm overrunning and can I speeden up. And so what we don't realize is what we're offering is not probably the gold standard. But I think when you start talking to clinicians and sort of explaining what we're getting from patient feedback and playing videos and so on, people do come around to realizing that there's a healthy blend of both online contact and using technology. And I think we've got to realize that it's a combination of both. You can't completely replace one with the other. The other thing, of course, is keeping the technology simple. Because the moment you start getting very complicated technology and pressurizing everybody to change within a week, it's not accepted. And I've got a very old computer. I turn it on in the morning, go and make myself a cup of tea, go to the toilet, walk down the corridor, and I'm usually interrupted by 3 nurses who want to discuss a patient, and it's still preparing my desktop.
That's what Martin said earlier. Yeah.
So it's got to be simple, it's got to be easy to use, and really important, it's got to fit in with the pathway redesign. It's about how it actually fits in with this whole clinical care process, rather than saying, here's this really clever piece of tool, can you look at how best you use it? But rather going back and saying, what are the bits of your pathway that don't work, that you want to improve? And here's all the stuff. Is there anything there that you can use?
Yeah. So, sorry, last question while I'm hogging, is that if you were advising Sam about the 30% outpatient reduction by 5 years' time, is that in your bag or not? No, thankfully not, probably for you.
Advise away.
But if you were to advise on how to speed that up appropriately, given it's taken you so many years to get this far, what would you be saying to her, or let's say NHS England, particularly about managing the consultants or the clinicians?
So again, I'd come back to one size doesn't fit all. We've often, the feedback we get from focus groups is people often like a pre-existing relationship with a clinician, rather than it being thrust on them first straight away, and that's something to bear in mind. Different populations are different. So we are finding for example, East London is very different to, say, Norfolk and Norwich in terms of digital exclusion, age of the population. Even the adolescents in East London are different from the adolescents in Norfolk, for example. So it's got to be co-designed with patient groups, it's got to be co-designed with clinicians, it's got to be evaluated, and you've probably got to keep reinventing the process as you go along. And if you start off with the 30% reduction, you're unlikely to get it.
Yeah.
But if you start slowly and then build it into the pathway, which you need to redesign, I'm sure we'll get to a very healthy balance.
Thank you. Sorry, and one last, if I can sneak again in. What's in it for the consultants? I mean, does it free up their time? Does it make life easier for them, or why would they do it?
So lots of us as part of the scaling up work. So we've been working with various teams across the country, and the feedback's really quite interesting. So, for example, we're working with Tom Kosker, who's an orthopedic consultant at Oxford, and he runs a sarcoma unit. And apparently they're one of 5 specialist centres in the UK. And so they get people who travel from all over the country, and sometimes overseas, to come for benign surveillance of sarcoma. And they spend a huge amount of time and money. They get a family member accompanying them if they're coming from overseas. They book into a hotel the night before, and then they come up for a 15-minute appointment. But worse is, if they get a malignant tumor who's breaching a 2-week wait, they bump this patient off the list who's made their travel arrangements or who's made plans. So, of course, no one's happy. So what he started doing is he's now using Skype for Business because he wants to share the radiology, for example. And last week he was telling me about this patient who'd come from Bristol normally, and she did an online consultation. And she normally would have had to book someone to look after her husband because she's a carer for her husband. She'd have to travel from Bristol to Oxford. She'd have to make arrangements to stay the night before.
So it makes sense for patients, I suppose, what I'm getting at. But does it make sense for the doctor? Yeah.
I think for the doctor, there are various things. One is I find that I have a far better relationship with my patients because as a diabetologist, I might sit and talk to a patient about a healthy lifestyle and diet and all of that, and then I sort of do a Skype on their computer, and then I find, they're living in a not ideal home circumstances in East London. There are lots of pressures on them, And then I sort of think, well, am I giving them the right advice? Can I do something slightly differently? You know, I talk to a patient and I say, what's that photograph? And she says, oh, that's my husband. And I say, oh, you know, is he in the country? What do you do? And she says, oh, my husband's visiting next week. And then I start talking about pregnancy planning and contraception.
Okay.
So, you know, it changes your relationship with the patients hugely.
Okay, thank you very much. That's very, very helpful. We'll return to that because there's a lot more to say. Fiona, right, you have a very different position here because you're at the BMJ and you've been there for a while now. How do you see where do you see the energy in forgive me for keep focusing on the medical profession, not just in, you know, thinking about this or this, you know, gamma knife here, some gene splicing there that might get the scientists really excited in medicine, but where do you see the medics sort of embracing what this might do to their profession as a whole? Do you see much leadership going on? I'm thinking about the colleges, regulators perhaps, I don't know, HEE. Who's really thinking about this kind of thing in the way that the Suskins are?
Thanks, Jennifer. I think there are lots of different aspects to this, and I've been listening to the conversations earlier today. We've got the sort of AI automation machine learning piece, which may well influence some of the diagnostic pathways and professional lives in that way. And we've got the kind of remote working, the way in which that can free up and change the way in which doctors and patients interact. We've got the administrative tasks that could be simplified or removed altogether. We've got how patients and doctors communicate with each other. And, you know, simple things like having access to the medical record and having letters that are written directly to the patient and therefore are framed very differently to the days when one would receive a letter, even if the patient received the letter, it was written to their doctor. There's a whole load of very interesting cultural changes going on, which are partly facilitated through things like email. And then you've got the whole self-care thing, which I think is hugely changing everything, where in fact the patients are taking responsibility for their own care. And I think in terms of the kind of clinical leadership of which bits of those are going to be most innovative and which bits of those are going to move fastest, I think we'll see that where technology can really change the doctor's life, where technology can really make doctors' lives better and they can really see benefit to patients in terms of safety and patient experience. Those are the areas where adoption, I mean, my guess is where adoption will be faster. Matt Hancock talks about, you know, he very optimistically that technology will save time, it will save money. I think we have to be a bit skeptical about both of those things. And I was thinking earlier while I was listening to people about what some principles might be about the types of technologies that we should embrace as clinicians. And you know, we've talked about patient-centered. I think that has to be a crucial thing. Co-designed, co-created by the patients and by the clinicians using it. Transparency and accountability. I think the fear of the black box, the unaccountable, unknown algorithm that you know is quite a fearful prospect, has to be evaluatable, whatever the thing is. I think it has to ideally head towards equity rather than the reverse of equity, because we know we've got such huge inequity in health and social gradients, and the technology has to be tested against, will it increase or reduce equity. There has to be choice. You know, this is we all have different choice in our lives. Do we do online banking? Do we do online booking of airline tickets? But some people still might want to go to a bank or go to a travel agent. So the idea of going in to see your doctor when it feels crucial. And I think you know, underlying it, as I've said, it must improve the quality of a clinician's work, and that's to do with how human they feel they're able to be, Simon Eccles' point, and how much they see the patient benefiting has to be, you know, that we have to be sure about the improved care and improved safety. So I sort of thought to myself, well, what will it take for clinicians to engage? And you know, not in very great order, but I think the clinicians themselves have got to be open to these changes, but they've also got to be, because you know, hopefully clinicians are naturally a bit skeptical as well. So you know, not just the new gizmo, but has it been evaluated? What about the risk of overdiagnosis and over-detection and over-treatment, which obviously a lot of technology we know does bring. I think it has to be patient-centered, has to be co-designed. We've talked about outpatients. We have to have a system redesign along with the technology design. I think that the doctors have to be incentivized, and a lot of the problems, I think, are some of the new technologies doesn't have an incentive system underlying it. So do you get paid for video consultation the same way as a face-to-face? All those sort of issues. It takes time to adopt new technology. Are they given time to do this? It takes time to innovate. Someone earlier made the point that you get time for research but not time to innovate. It was a very, very good point. And I think doctors are going to have to be ready to relinquish some of the power, and that's partly patient, giving power to the patient, but it's also giving power to nurses, giving power to other parts of the system that they might feel they want to hang on to. And the truth is there's no shortage of work, so and we've got a great shortage of doctors globally. So things, if we can get pattern recognition in imaging and pathology, and the radiologists can therefore spend more time deciding which is the next best test, which is the multidisciplinary team working with their colleagues, there are lots of ways in which that time could be better placed. So I think we shouldn't be fearful of relinquishing some of that power and work. The leadership thing, we do want clinicians leading. I think we want many more clinician CEOs, and that's not because we haven't got great non-clinician CEOs, but I do think there's a great value to having clinicians at the top of these organizations. But my final and slightly worrying for perhaps an audience of this demographic is that I think you're going to have to be young to embrace technology, and I think we're going to need, there are a lot of us who are going to have to just retire and leave before the real technological revolution is going to happen, because we all know that our kids don't even think that it's digital, it's just the air they breathe. And rather like in publishing, we don't talk about digital publishing anymore, it's just publishing. Shanti and I were on a webinar the other day, and we talked about the moment that we know we've been successful would be when we don't talk about digital, it is just healthcare. So
thank you. I'm going to ask one more question, and then I'm putting you on notice that maybe to think about a question you might want to ask. The one thing I wanted to say about the medical profession and the leadership is that there seems to be, I'm going to make a gross generalization here, an inbuilt propensity to be interested in scientific things. If you think about medicine and the way it's gone, subspecialization, against, in a sense, generalization and so on. And you sort of see that in a bit in the industrial strategy, don't you, in the life science agenda. Everyone's getting very excited about this or that, life science, as I say, gene splicing, metabolomics, gamma knives, all this kind of stuff. And yet the kinds of things we really need, which you're talking about, Shanti, are about changing services, changing elements of services, which are generic. And are the medics really interested in that kind of stuff? Don't they think that's management? So my worry is that, sorry, there's lots of worries which are boring, but there could be a danger, couldn't there, of more people within the medical profession leading this, just taking us down a super specialization route and actually forgetting about these big service changes, unless there is a sort of locus of leadership energy that is clinical energy, that is not orientated in that way, and maybe they've got to be in the system, maybe you're a clinician after all, sitting next to management that can make sure that these generic things are done.
I hope not.
That's for you, Fiona. Take it away. Well, we can leave that one hanging, and I can ask you, because you're all extremely talented. What do you think? Yes, Nick, and then the lady next door, and then this lady. Just yell if there's a delay with the mic.
Okay. It's actually an answer to your question, Jennifer.
Thank you.
Because it struck me that one of the things that hasn't been mentioned, I think all day, is the medical industrial complex.
Yeah.
And if you look at the technologies, everybody always goes on about how difficult it is to innovate, and it takes 10 years, 15 years for effects of randomized trials to take. At the other end, laparoscopic surgery took 18 months to go from open cholecystectomy to virtually no open cholecystectomy, and all laparoscopic. Why? Because of the commercial interest in flogging the kit. And the boys liked the new toys, given that most of the surgeons were boys then. We're seeing the same again, with no clear evidence of any benefit in terms of patient outcomes or patient experience. We're seeing the same again now with robotic surgery. Now, that's being driven to a large extent by the doctor industry and common interests there. So
And
I
the
think
industrial strategy sort of encourages, I mean, I don't want to diss the industrial strategy, but there is a bias in there,
Yeah.
isn't there? With that?
yeah. So I think that now, on the other hand, the sorts of brilliant things, Shanti, you're talking about, the transformations, there's no commercial interest. There is no industry who's going to actually want to will benefit from what you're doing, which is far more important, far more profound for the public and the benefit of the public. So that's the mismatch I think we've got.
Yes, thank you. So we'll just hold that. So that's commercial determinants of innovation. I think there's that. Yes, next door.
Hi, my name's Stephanie Jordan. I'm a Care of the Elderly Registrar and a Clinical Fellow at the GMC in Leadership this year.
Great.
It's a question for Shanti. I'm interested to hear about your work in the diabetes service. Questions about unintended consequences. So I'm thinking about our Parkinson's disease clinics. Quite often those clinic appointments are labelled as the routine follow-ups, end up being quite a good opportunity to do advanced care planning for patients. So I just wondered, have you looked at unintended consequences in the service, or have you found any?
Sorry, let's just hold that. I will come back to you. There was one other person who'd had that. Oh, yes, there. Thank you.
I suppose
Yep, you're on.
I'm a GP, and it's interesting for me to hear because I don't work in an area where actually the whizzy stuff exists. It's interesting coming to these events and hearing what sounds to me like a very acute focused approach to innovation. And I suspect some of that is because a lot of and I'm now actually working for a community service in a Care of the Elderly service, there's something about innovation being very, and QI or whatever it is, being a very acute focused function. There is a lot of innovation that goes on in general practice, and I think general practice has adopted quite a lot of things themselves. One of the difficulties is it tends to be different practices doing the same thing in different ways. This is more of a comment, but it would be really interesting to see a bit more national work done on how you might innovate, and I think PCNs will help with this, how some of the innovation work could be embedded in general practice, because practices are doing a lot of this work. My other comment is, when I see this thing here, a lot of what we do in general practice and in Care of the Elderly is actually about shared decision-making. And I'm not sure that process takes on board shared decision-making, because a lot of the standardization and systematization, you can do some of it in general practice and Care of the Elderly, but a lot of it is about how you make decisions with your patient, with your carer, that are not actually within a standardized concept. So I'm being a bit of a comment person. It would be nice to hear more about general practice. And there is quite a lot of innovation going on, and also a lot of what professionals, and they're not doctors, they're all clinical professionals, do is about shared decision making, and I'd be really sorry to see that get lost, because actually things aren't as standardized as you think they are in terms of decisions.
Thank you. So I'm going to take one more. I'm listing those, so you don't have to remember them all. Just Ramini, last question for the moment.
Hi there, thank you. Ramini Munisinger. I'm an anaesthetist, and just to pick up on that last comment, so I think the shared decision-making falls into the craft, and I think that the standardization and systemization will take off a lot of the workload that can sometimes, that can be standardized and systematized, and the things that can't, the shared decision-making will be given more time, and we all know that GPs and geriatricians and anaesthetists and everybody else need more time. Going back to the discussion about medical leadership, I think different Royal Colleges are taking different approaches to this. I think the Royal College of Surgeons and the Royal College of Anaesthetists are both really thinking about this. So the surgeons have recently concluded a sort of look to the future about the impact of innovation in their field, and the College of Anaesthetists is moving very much towards the more holistic care of patients rather than the specifics of what we do in the anaesthetic room, because so much of that will become automated over time, and the machines will probably end up doing it better than the humans could with interference. So I think that some of the Royal Colleges are really progressive about it, and in the end, this is about providing the best care to patients and the best value for the health service, and thinking about how we can standardize and systematize in order to improve those things, rather than worrying about defeating professional objectives and so on, I think is the key.
Just one last before I go to the panel on those questions. You will all have read of Atul Gawande, won't you? And also Don Berwick actually, and they've been talking a lot about the emotion of medicine, the relationship side of things, which is really, I suppose, in the crafty box sort of thing, perhaps. I don't really see that kind of level of discussion here. Really, I mean, I'd be interested to hear from you all where you see those things surfacing through clinician leaders. Anyway, while you're mulling over that, I think this question about what I'm calling commercial determinants that Nick mentioned is quite interesting. And then Sam, I wanted to ask you about that, maybe Fiona, because Sam, part of your job is assessing what the needs of the NHS are, not just what the commercial interests are that are bouncing off the NHS. Yeah.
Yeah, so we have maybe a slightly less extreme view of the world of it being entirely commercially driven, but we have definitely recognised that there is an issue with innovation of the balance between it being supplier driven and demand driven, and certainly the balance historically has been on the supplier side. So we're very, in some ways, passive recipients to suppliers saying we've got this, and so we've been doing a lot of work with NIHR and the AHSN network to try to ask. Starting with national policymakers and then moving to STPs and local leaders, what are the needs that you have that you think research and innovation could help address? And obviously research is different from innovation. But actually that's, so we've started that, we've had like 67 interviews and 267 survey responses and the report is published. But you realize this is a completely new kind of conversation. So it's not like people have that at the top of their minds because it's the first time they've been asked. So I think we're at the very start of the journey, but we absolutely recognise what you're saying, that we need to be articulate about our demand and kind of focus our resources, both clinical and financial, where we see the need, not just on what the innovation is.
So it's an old question. I think the NHS R&D grant is about 1% of NHS spend, isn't it? And it goes
yes,
through.
That's exactly right. 1 billion to 110 billion. Or
goes
whatever.
Through NIHR.
Yeah, exactly.
And it's a cliche to say that it's mostly R and not D.
Yeah.
But somebody said earlier, if we could have a bit of, they didn't quite say venture capital, but if there was some kind of capital fund. I mean, at the moment it's a few organisations funding, or NIHR does a bit. We do a bit. The foundation. There will be others, but and a lot of our sort of small-scale innovations have been scaled up and now are pushed out nationally, which is nice. But could there not be a more of a fund for this type of thing to give people the space that would help Shanti maybe, so it doesn't have to come out to us all the time, although it's very nice, or others, or maybe even some social impact, NHS social impact investing, I don't know. I mean, is that something you're thinking of?
Yeah, so actually there are funds for development. They're way smaller than the NIHR budgets, which make of that what you will. But what our impression is that in the pool of funds, there are 38 different programs. So we're definitely not getting the bang for the buck that we need, because you as an innovator are getting a little bit of money here and then you drop off a cliff and then you get a little bit of money there, and you as a trust are getting a little 6 months of a project manager and then there's nothing. And so that's one of the jobs of the Accelerated Access Collaborative, to say, okay, let's all pool our collective funds and let's have a bit more of a funding pipeline where we go, right, we provide significant funds at prototype stage, significant funds at real world testing, adaptation stage, and a bit more standing infrastructure in the NHS to support that rather than little itty bits.
Yeah. So Shanti, perhaps you wanted to say a bit about that, but also particularly this idea that I think it was that virtual consultations could actually drive out some meaningful conversations that are needed to be had, that are wider than, that you have to really do face-to-face, such as advanced care directives and so on.
So a couple of things. One is, in terms of the commercial relationship, the other things we haven't actually mentioned is quantitative outcome measures. So, clinicians are really obsessed by showing that there are positive quantitative benefits. And we are showing a 5 millimole reduction in HbA1c in people who are engaging with online care, because it really helps self-management. And so to me as a clinician, I'm less concerned about the commercialization of the whole thing, rather than to be able to prove that my patients are getting better quality of care at the end of it. So I wouldn't underestimate that. And the second thing is the lack of a competitive tariff is a serious disincentive for organizations for digital care. And unless that's addressed, even if it was commercialized, it would still be an obstacle. In terms of unintended consequences, we've done some work with the HPV cancer team at our hospital. And they're using online consultations. And actually, one of the myths is cancer diagnosis is probably best discussed face-to-face. And what a lot of patients are saying in focus groups is actually they'd much rather have that conversation from a physical space they're comfortable in, surrounded by a member of the family, and not having to make a journey on the underground for 2 hours, hear that the cancers come back, talk about treatment plans, and get back on the train crying all the way home. So, I think there's a lot we assume, and again, this is the clinician mindset, that certain things are best done face-to-face by a doctor and a patient in a cold outpatient clinic room. And somehow it requires us, and that's why one of the things we're doing with HEE really is to start talking to doctors in training and nurses in training, because coming back to you, I think we're all past our sell-by dates, most of us. And really,
Speak for yourself.
Speak for myself. But I think a lot of it is junior doctors, doctors in training, junior nurses, because that's where the change has to come from, I think.
Thanks. And then there was a nice question about primary care, that a lot of our discussion was acute focus, but actually you're saying quite a lot of innovation that happens in primary care anyway. But also, I don't know about you, my practice, sort of yes and no, I suppose, is the answer. Some of it, they're still pretty antiquated, I would say. But I don't know who wants to take that one on. Yeah.
I can pick that up. Yeah, this was a big topic during the long-term plan development, and we absolutely recognise that, and that's why there's, in the new primary care network contract, there is the funding for test beds, which is this idea of,
nice.
Can you take things that looked promising in one practice or group of practices and then test it in multiple practices, see exactly as we talked about, see how you would change the pathway, see whether it works with your payment mechanism, see whether it works with your staff types, etc., and then it can be rolled out. Completely. Yeah. Completely.
Yeah.
To be fair, we had Martin Marshall did a lot in the.
He did a lot.
We had in the parallel.
Yeah. Completely.
Minor changes can make a big difference. The other thing we haven't said is sort of throughout the threads of running through the day, not that I like to necessarily always fly the flag for quality improvement, but the quality improvement techniques systematized can really speed up this testing and changing and adaptation that we were talking about earlier, which will speed up. And actually the Royal College of GPs have been in the vanguard of that, haven't they, with their QI ready tool. So they are quite right on in that respect, if I can say. Now there are a few more questions. So yes, gentleman over there, and yes, the gentleman there.
Paul Batchelor from the Faculty of General Dental Practice. I mean, I'm just picking up on first Nick's point. In a few years' time, you'll all be getting white fillings rather than silver fillings, which is part of the dental complex about generating work, so be wary. The real issue, though, here is that we tend to be talking, or at least what I've listened to, about care provision once a diagnosis has been made, or the diagnosis. We've seen in the health system a move now towards recognising the determinants of health. I'm not sure whether the medical or all healthcare professionals have yet worked out how best to deal with the determinants. And the real question is, what role do the undergraduate schools, the health facilities, have in this process, so that at the first exit point, i.e. when you get onto a register, what is the roles or what are the skill set that you should have, and how do you bring about those changes, say with the regulatory body and the GMC?
So not necessarily technology per se, although there may be a tech element to that if more people are using their smartphones and Google Health and all that. So there was another question there, and then we will have the last comments from the panel.
Hi, Alistair Mitchell-Baker. Many moons ago in a different world, I did a lot of work to support Lord Aradazi's Healthcare for All review in 2008.
Oh, yes.
And I must say, Sam, this sounds exactly the same stuff that came out of that, pretty much. And yet the challenge is still there. I don't think it's so much about research, development, innovation. It's about adoption and spread. And something in our mindset means the not invented here, or the we somehow can't spread what are evidently great innovations, whether it's from one hospital to another, or one department to another, or one practice to another. And I'd love your comments on that.
Yes, so that is, I think that's probably a good question to end on. We're not losing the social determinants. I mean, I thought Simon was great this morning, but he didn't really address the issue of culture, did he? And how to up the speed of change through that mechanism. It was through the kind of pokey, nudgy things, regulatory things, as opposed to the things from inside the guts of the NHS and the culture. So anyway, so let's have some final comments on that.
Yeah, I completely agree with you. Adoption is kind of 80% of the challenge. So I took the job as Director of Innovation at NHS England a year ago, and pretty much everywhere I went, I was told the NHS can't adopt, the NHS can't adopt. And there's little bits of literature on where we have successfully adopted, like some lovely stuff in the BMJ, for example. But I kind of thought, for me and my team, this is the number one thing we have to do this year, is to see, can we find examples of where the NHS has adopted things relatively quickly. So we're very lucky to commission the AHSN network, and we kind of identified with them, which I know is very supplier-driven innovation, but kind of given the time frames, we decided to go this way, with 18 different innovations that range from primary care, mental health, secondary care, etc., to say, over the year, can we see if we can adopt some of these innovations in the NHS? And we gave them trajectories, which was like, so most of these were post-NICE appraisal. Despite being NICE appraisal, less than 3% of the eligible population was getting access to these different technologies or devices or different pathway changes. And we worked with the AHSN network to see if we could increase that. And I have to say, across that 18 innovations, we got increases of, our best increase was one relatively simple device that went from less than 3% of the eligible population to 66% in a year. And probably our least successful was something that went from about 3% of the eligible population to 10% of the eligible population. So I feel like we have some credible data to say, it's not that we can't do it, it's that we don't systematically do it. So now our question is, well, so if we could do it relatively successfully in 9 of those 18 things, what was happening on both sides? So what was the spread out organisation doing? Because we saw differences by AHSN. And what was the adopter organisation doing? And as the AHSNs went round, they collected great data on the level of adoption at each of the sites they went to. So we've got all this beautiful data of who took these things on and who didn't. And you see huge polarities between trusts and GP practices, etc. And so now we're doing work on, on both of those questions. So what were the spreaders doing that worked, and what were the adopters doing that worked? So I wouldn't be too negative where you are. I think we've got credible evidence that we can do it, and now our job is to just do that more systematically.
And I'd like to draw your attention to the spread challenge.
Indeed, which we're very interested by.
The Health Foundation published, which drew from our portfolio for the last 10 plus years on why things spread and why things didn't. Shanti, thank you very much. Shanti, your last word on the...
So, following on from what Sam was saying, so as part of the scaling up work, one of the things we've been trying to do is to work with early adapters at various sites. And so, for example, at Oxford, so we've got this orthopedic team who are obviously very keen in doing this. And so Jo, who's our research manager, then contacted a few other specialties at Oxford, like the oncologists and the diabetologists. And what we're trying to do is to create a hub at each site. And the idea is that hub then acts as a local pod for everybody who's interested around there, and then that helps spread and helps diffuse good practice. And so the idea is, at every site that we work with the team, we try and hopefully create a hub there, which will try and disseminate locally.
And hopefully the humans will collaborate. Thank you. Fiona, your last word
Well,
on that, maybe.
Only just not so much on the content, but on the process, and really I'm just going to say, delighted that the BMJ has been part of this really lovely day. And wanting to say to you all that the BMJ's role in this, I hope, will be partly to help to disseminate and share ideas, evaluations, of new technology, really scrutinise those, but also the kind of cultural leadership and the sort of individual responses to these things. So we have a number of different formats we'd really welcome your input into. We have opinion, we have our letters columns, we have our analysis, we have the research, we have education articles. So if you are aware of good things happening or challenges or bad things happening that we'd really want to hear from them. And Jennifer and I are talking about hopefully a kind of series of articles that might come out of some of this work to really help to push the agenda forward. And please do contact me, fgodley@bmj.com, if there's stuff that you think we should be covering.
So thank you very much to the panel. I think the medical profession can live to fight another day. I don't think anything's going to happen anytime soon, it sounds like. And they are maybe in control of the speed of change. But thanks very much to Fiona, to Shanti, and to Sam for a very interesting panel, I think. And to be continued is probably the operating phrase here. We are now at the end of our day. I hope you've really enjoyed it. Thank you so much for participating, all the speakers, but also all of you for being here, spending your time, and also for contributing in questions and so on, and the Slido. I particularly want to thank, from our end, this stuff doesn't happen, does it, just by chance? So I particularly want to thank all the Health Foundation staff who made it happen. In particular, comms colleagues Sushma, Gemma, Laurel, and Navdeep, who have done sterling jobs. I'm sure I've missed somebody out. If I have, I do apologise. I can see my colleague at the back. But they got up very early, so I hope you were well looked after. And now I think there is something which is called a networking reception, is that right? With 4 glasses of wine. If you haven't had your fill from all the QI stuff, you can then have more discussions at the back. But just to say, for me, from the Health Foundation, it is just so very nice to both pull together lots of strands of our work, but also to pull in some people that we've worked with over the years, that we hope that all collectively we're on this kind of journey, whether it's quality improvement, whether it's safety, whether it's technology and automation, whether it's the social determinants of health, as you see we're moving into that, or whether it's some of our international fellows that I see in the audience. So really pleased to have you here as part of the fold and the ongoing conversations, and rest assured we'll be on the case and look forward to seeing you this time next year. Thank you so much.
Thank you.